Hello, my name is Vicky Terry and I am an advanced physiotherapist specialising in trauma and orthopaedics at University Hospitals of North Midlands NHS Trust. Following a total hip replacement, there is a risk of dislocation. These can occur within the initial stages of recovery or several years post-surgery. The first line management of these individuals is to undergo a manipulation under anaesthetic. The orthopaedic consultant may then advise range of movement restrictions, which can be accompanied by the use of a hip brace. When a hip brace is requested for the patient's management, this can significantly delay mobilisation of the patient, impact on quality of life when complying with its use, and delay discharge from hospital. At UH&M, the orthopaedic consultant preferences vary widely. During a 6-month audit between November 2018 and May 2019, 16 patients were identified with a total of 24 dislocations, 15 of which had previously dislocated. All 24 dislocated hips underwent a manipulation under anaesthetic. 18 surgeons were involved in the patient's care. Post-surgery, 14 patients were managed in a cricket pad splint to immobilise the knee joint on the same side. 2 patients were placed in a hip abduction brace and 1 dislocation was irreducible in theatre. 2 patients placed in the hip brace had previously dislocated their hip within the last month. There was no apparent correlation with the selection of the cricket pad splints. Mean length of stay for these patients was 9 days, increasing to 19 days for the 2 patients managed in the hip abduction brace. As a result, we sought support from the Allied Health Professional Musculoskeletal Group, getting evidence into practice at Keele University. We were able to use the CAP process to answer our question, which was, does the addition of a hip brace limiting flexion and adduction of the hip when used post-relocation for primary hip dislocations prevent recurrent dislocation when compared to usual care, being hip precautions and advice, or no intervention in adults who have a hip prosthesis? We also repeated this question for recurrent hip dislocations. Our search found 4 potentially relevant papers, 3 service reviews and a Cochrane review in 2006. There were no randomised control trials to provide any robust evidence. We contacted the British Hip Society to establish any current guidelines, and they were able to confirm that there was no guidance from the BHS at this time. In conclusion, we feel high-quality research is required to help healthcare services establish the best interventions when managing prosthetic hip dislocations to improve patient care. In the meantime, as the little evidence found was not of high quality, our practice remains unchanged. We propose to undertake a further audit within our trust to enable the costing of delays and patients' perspective of coping within the hip brace, to understand the wider picture of this form of patient management. Thank you for your time and listening.